Okay, you want to start, Kim?
Hi, welcome everybody. This is Kim Stevens here, Program Manager at North American Council on Adoptable Children. I'm really sad, as I'm sure that Barb is as well, that we can't be there with you in person again. We were so looking forward to our return trip. But I do want to say a huge thank you to Kate for making this happen so that we could at least join you virtually. And we are also incredibly excited to have Dr. Susan Rich here to talk with us. I'm going to turn it over to you, Barb.
Great, yeah. Well, good to see everybody, the few faces that I can see, but it was fun to be there in September with you guys, and we are sad we're not in person, but one of the cool things about doing it online is that we can actually bring in a variety of experts to help with the various topics that we wanted to cover on this next session. So my name is Barb Clark. I'm the Parent Support and Training Specialist at the North American Council on Adoptable Children. Really happy to be here with you guys, and with that, because we have so much information, and Dr. Rich is she is an expert and has vast knowledge on this subject. So we're just going to hand it over to her so she can get going. Go for it, Dr. Rich.
Thanks so much, everyone. I'm delighted to be in North Carolina again, although virtually. It's my avatar that's there, right? But my avatar will always live in North Carolina. Today, I want to share my insights and perspectives on clinical screening and diagnostic approaches to ND-PAE. I did send last night a couple of things to Barb. One of them is a screening tool, which I hope to get into a little bit, but you should have a copy of that. The cover slide that you're looking at is actually the cover of my book, which goes into a lot more depth about everything that I'm talking about, and that is The Silent Epidemic, A Child Psychiatrist's Journey Beyond Death Row. So I'm just going to jump into this now. If I can get my my slides working here. There we go. So giving you a little bit of background, since I am from North Carolina, about my personal and professional perspectives and how I came to know about fetal alcohol spectrum disorder. I'll go into a little bit of the epidemiology and prevalence, just because I looked at what Barb has done already in terms of training and looked like, you know, maybe I could do a little bit more to help folks understand why this is an important topic for children from foster care and also who are adopted. And then a piece about the neuroteratology, because if we don't, you know, share enough about neuroteratology, it's hard to know what these neurodevelopmental disorders are coming from. And then going into the DSM-5 criteria, what is ND-PAE, and some about the screening tool, but you have a copy of the screening tool there, and it may be that at a later date, if any of you would like, I could come back and really do a more thorough look at that, and then some treatment and prevention issues. All the way back in April of '92, I worked for Burroughs Wellcome Company, which is now GlaxoSmithKline in Research Triangle Park, and right near Duke, where the Center for, what is it, Family Services, Kate?
Child and Family Health.
Center for Child and Family Health. And not saying that, you know, I am a Tar Heel, I have to tell you, and from NC State. So although you're from Duke, it's okay. We can all be in a team together, right?
Just because Duke, we work for Duke doesn't mean that we're not Tar Heels.
There you go. Yay, because most people in public health who are doing really great things are from where? Let's be honest, UNC. Anyway, I'm biased. So the situation was that I was working in pharmaceutical research right down from George Hitchings and the other Nobel laureate, Gertrude Elion, for, you know, the two people who had won the Nobel Prize back in 1988. And I read a book while I was working in pharmaceutical research about fetal alcohol spectrum disorder. It's called The Broken Cord. I don't know how many of you have read it, but it's really a must read for anybody who are working with these children. I read the book. I eventually left my job in pharmaceutical research and then went back to school because of this issue, really recognizing that this is one of the leading causes of preventable neurodevelopmental illness and really intellectual disability, as well as a variety of other things. And it just happened that at UNC Chapel Hill, Dr. Robert Cefalo and Mary Kay Moose had written a bunch on preconception health, and Dr. Kathy Sulik, who became my mentor, Dr. Cefalo was as well while I was a medical student, but Dr. Kathy Sulik had shown that it's the late 3rd to early 4th week of human development that a lot of these problems happen. So I've gone on with my work to really delve into this as an issue for individuals who have chronic and persistent mental illness, and really learning how to prevent it. But with that, I went on, I did my Master of Public Health and then eventually my Doctorate of Medicine. And while working on my Master of Public Health, I worked with the North Carolina March of Dimes and developed a program for Tuscarora women, which I'm enrolled in the Tuscarora tribe of North Carolina, to help them understand that they need to plan their pregnancies carefully, because this problem can happen very early in pregnancy. Eventually, trying to get my slides to work here. Of course, I worked for March of Dimes, went to powwows and festivals around the state, including all the way down in Cherokee, North Carolina, teaching about how birth defects happen very early in pregnancy, and eventually developed another brochure, What is Family Planning, for Native Americans in Robeson County, North Carolina.
Hello.
So going on, I also worked with the attorney that worked with one of the co-defendants in the murder of James Jordan. This was a young man who back in '93 had murdered James Jordan. I saw his picture in the paper, Larry Demery, and I went to the attorney in the case and I said, you know, I am a public health student at UNC, and I think maybe, you know, you could help me, because I have recognized that it's a possibility that one of your defendants have this condition. And sure enough, we got Larry Demery up to the FAS program at Wake Forest University, and he was diagnosed with fetal alcohol effect at the time. I went on with Dr. Kathy Sulik to do work in her, not in her lab, but with her, and developed a number of programs, including a documentary on FASD. And if you can find that, if you look under YouTube, just go on YouTube, or even in Google, Dispelling Myths About Alcohol-Related Birth Defects. So a lot of this is on that YouTube video, which was a CDC-funded grant through the Center for Birth Defects and Developmental Disabilities at the CDC. They funded Dr. Sulik, and she and I did a documentary, and she went on to produce a training manual for kids in schools all the way down to 5th grade, and it's available through Carolina Biological Supply, so you can get that. And it's a great resource for teachers and parents and anybody who wants to help children understand this problem all the way down to, like I said, 5th grade. That said, I've also been on the National Organization on Fetal Alcohol Syndrome Board of Directors. There is the former First Lady of Minnesota, as you see, Barb, Susan Carlson. She's still on the board. I actually stepped down around 2011. I really didn't like it that they were taking money from Big Alcohol for some of their fundraisers, and that's really why I stepped off. I'm, you know, a physician, and we're not able to take money from Big Pharma, so I couldn't understand why NoFast was, you know, really partnering with Big Alcohol, but that's just my thing. So I have no complaint otherwise. And then I worked with Good Morning America while I was in medical school as an intern. We developed a short form documentary for the healthy woman on the increased incidence of fetal alcohol spectrum disorders from 1991 to 95. Maternal alcohol use went up nationally by 400% from 1991 to 95. So in 97, when I went to work for Good Morning America, that was kind of, it had been front page news April of that year, and we produced a short form segment for the Healthy Woman on that, which I'm not sure is archived, but I do have a copy of it if anybody's interested. And then I went on to Canada and did a bunch of talks, and as a public health student, as a medical student actually, just on my own dime, and then somewhat with a little bit of funding for travel from my university, as well as from the University of Manitoba. And then out to the Navajo area of Indian Health Service, I did a number of outreach train the trainer programs. Actually, if you see in the picture right behind me, you guys might not notice that, but in this parade here, there's Bill Richardson. I think he's former governor of the state. Anyway, that said, while I was in New Mexico and Arizona, I worked with Navajo Family Health, the ARC of New Mexico, and the March of Dimes there to produce a booklet, Lifelong Happiness, teaching about preconception health and family planning in a culturally relevant way for the Navajo community. And I went around and did train the trainer programs all over the state for that. Again, really with the intention of helping people understand that it's going to take probably 7 generations for us to deal with this problem, but we need to begin today planning for the 7th generation. It's taken about 7 generations for us to get here since colonialization. It's going to take a while for us to get out of this problem. So that said, what is the problem? Well, we know that FASD, fetal alcohol spectrum disorder, is not just what we once thought. The combination of alcohol-related birth defects, which are identifiable at birth, the problems associated with fetal alcohol syndrome, which is very heavy, amounts of alcohol early in pregnancy, early binge exposures, and then what we used to call alcohol-related neurodevelopmental disorder, which is kind of like FAS without the face. What we now know is that there's this condition, neurodevelopmental disorder associated with prenatal alcohol exposure, which I will be talking to you about today. And these kids are those with and without the face. So as a psychiatrist, these are who I see, because I'm not going to do facial plastic surgery on children. I do see children who have cleft lip and cleft palate repairs. I've got one girl in my practice who was adopted from Iran, and she had a cleft palate, but a lot of other issues. And her parents always just focused on the cleft palate because it took 7 years for them to get that whole thing corrected with multiple surgeries. That said, as we move forward with understanding this problem, we know that the recent studies have shown that it's as many as 1 in 20 children in America have some of this problem. And where you get higher rates are in children who have been adopted or in foster care, because the reasons they're taken out of the homes often are because of substance use issues. A colleague of mine, very close colleague who has passed away last year in August, Carl Bell, showed in urban areas, so a lot of where we're seeing, people protesting today because of things like social determinants of health, we see very high rates. He found as high rates as 40% of individuals coming into his family practice clinic. Was a psychiatric practice embedded in a family practice clinic in Southside Chicago, so Hyde Park. He found 40% did have diagnosis of FASD. These were adolescents and adults, versus, another, like say 20% that he could not prove they had been prenatally exposed, but they had a lot of the features. Now, he was able to go back and interview a lot of the birth moms because he actually had those birth moms in his practice. He had been in that area since 1968 when he graduated medical school. and knew a lot of the families and was able to get really good histories, birth histories. But this is almost impossible when you're dealing with children who have been adopted or in foster care. Now, we know that the burden of full FAS is somewhere between 5.4 to 6.5 billion, but that's for full FAS. And because we know that of the children who have full FAS, they only account for about somewhere around 15%, maybe 20% of those affected. So you could probably take that number and you can multiply it by about 3 or 4 to get the true rates of FASD, the impact of the financial burden on the country. And for a $220 billion a year industry, I mean, I think this is really unacceptable, but that's just my thing. And I don't happen to be like an academic who's going to be mincing my words when I talk about this. I think we have a global public health crisis when it comes to this. And this is very much related to all of the social determinants of health that are affecting many, many urban areas in our country. And we need to start looking at this and taking a step back and saying to the alcohol industry, which is the cause of this, we need to put more legislation in place to prevent their marketing and their advertising and many things like that. But having said that, that's not what this talk is about. So I'm going to keep going. So when we look at foster care and children who are adopted, we know based on some studies by Dr. Ira Chasnoff that of the children in his studies, approximately 86.5% of those who had FASD were never previously diagnosed or they were misdiagnosed. And these studies have been started to be replicated in other areas. This is not something that I think many people have understood up until now, but children who are adopted or in foster care are at high risk of this problem just by the nature of the fact that many of them are taken out of the homes that substance use disorders are very prevalent. The other place where these children end up is in education systems which are really ill-equipped to handle their issues. So I've just listed here from the Maryland Special Education Early Intervention Services report from a few years ago, what are some of the disabilities that are classified in the state of Maryland? Now, this is not saying that all of the children who have these diagnoses have the diagnosis of FAS. It's saying, well, what are some of the places that we might find these children that we might give them better access to services? And that's in the students with disabilities within the Department of Education. Any school system, we need to start looking carefully at the children who are identified and many of them not identified, because what I've seen from kids who I evaluate in juvenile justice centers, so these are, essentially residential treatment centers, sort of court mandated treatment places. Many of these individuals never even had an IEP, but needed one. So that's, what I'm showing you here is some places that we might see the kids, some of the diagnosis that they might be given, but there are plenty more that are never diagnosed. And that's what Dr. Chasnoff's study pointed to, that many of them are misdiagnosed with other conditions, and also their diagnosis of FASD or anything else is often missed. So that said, why is this true? And why is it that so many of these kids end up with mental health problems, not just, let's say having learning disabilities and neurodevelopmental problems? Why do so many of them end up with mental health issues? Well, that's because there are multiple hits to neurodevelopment that happen through a person's life. So a prenatal exposure is very much similar to, say, a genetic issue or an epigenetic issue. And now with understanding that male use of alcohol, even up to 3 months prior to conception, is part of the epigenetic factors that contribute to neurodevelopmental problems. It's not just the prenatal alcohol exposure, it's also preconceptional alcohol exposure. So that's the first hit. And if you have genetic loading or epigenetic loading, it makes that prenatal alcohol exposure even worse. Then you get adverse childhood experiences on top of that. So witnessing or experiencing abuse, neglect, or sexual trauma, this type of thing. Those adverse childhood experiences then go on to contribute their own pathology to adult onset mental health issues. And then the third thing is alcohol, tobacco, and other drug use. So during adolescence, many of these children are at higher risk of developing substance use disorders because of their epigenetic phenomenon, and also because they're vulnerable to peer influences. So keeping them totally away from alcohol, tobacco, other drugs is very important, because that is the third hit to neurodevelopment that almost seals their fate for chronic and persistent mental illness. The thing that I want to preempt really my talk, and I know people say I'm slow to warm up. It takes me a little while to get into the meat of what I'm talking about, because I have to give you the background. Understanding neurodevelopmental disorder associated with prenatal alcohol exposure, you have to first understand that there are different types of birth defects. So there's physical birth defects. Those are defects that we can identify when the child is born. And there are functional birth defects that are neurodevelopmental in origin. And that means it's damage to the central nervous system and brain. And you may not see that when the child is born, or if you do see it, it's going to show up as these mild developmental disabilities, which oftentimes by the time the child ages out of their original IEP that they might get with infants and toddlers, and then they go into the school system in kindergarten, the school systems are really reluctant to give them an IEP, which it's because, their issues aren't really that predominant in terms of affecting how they're functioning. But in my belief, any of the children who start with an IEP up until their age 3, they need to continue that through the early parts of their elementary years. And that's kind of another story. But distinguishing alcohol from problems created by things like thalidomide, this is a difference between physical birth defects and functional. So if you remember the babies born to women who used thalidomide back in the 50s and 60s, these babies were born with no limbs. And this was a real big problem over in Europe and in other parts of the world where thalidomide had been used. Alcohol does not cause the same problems. It causes more problems to the developing brain and central nervous system. And it happens very early in pregnancy. This is, between neurulation, gastrulation, neurulation, and at the end of the first about 8 weeks, your brain and your face are forming. So she's just missed her period, but she's a sexually active social drinker whose periods aren't regular because she frequently binge drinks, and her periods aren't regular because alcohol is a estrogenic compound and it messes up your periods. So between missing the first period and missing the second period, she's starting to think, well, maybe I might be pregnant. And so she'll go out and get the pregnancy test, and she says, yes, I am pregnant. And if she's getting good advice from her mother and her grandmother and people around her, she may stop drinking, but maybe she has a drinking problem, or maybe the grandmother and the mother drank themselves and they're like, a little bit's okay. And what's a little bit to her is a Long Island iced tea, right? Which contains 6 shots. So what Dr. Kathy Sulik showed is it's actually the late 3rd to early 4th week post-conception. So during these very early stages, when the brain and the spinal cord are still open, that as little as 4 to 5 drinks can cause the full fetal alcohol syndrome. Okay, and remember, I'm not talking about the full fetal alcohol syndrome today, but I think there are plenty of babies that are exposed during this window. And then if you ask the women, did they drink when they were pregnant? They would say no, because they drank prior to pregnancy recognition. And you have to remember that these early stages are equally important. I'm not saying more important, because if she drinks at any point in pregnancy, it's a problem. But if she drinks in these early stages, it's really, it can be damaging to the baby, especially if she's drinking a binge amount, because it can cause the full fetal alcohol syndrome. And this is when we are about the size of Roosevelt's ear on the dime. Our little tiny, the organism, called the embryo is about half brain. And if you see in this picture, and I'm not sure if you can see my arrow, but you can see that half the embryo is basically going to be brain, and all these little bumps here are the somites, which are going to become your spinal cord. So when you talk about the posterior opening of the spinal cord being open, that's spina bifida, and the area of the spinal cord being open and the brain is called anencephaly. And babies can be born with neural tube defects associated with prenatal alcohol exposure, and that's due to very early exposures. Again, the face is forming in that very early window. So 4 to 5 drinks late 3rd to early 4th week can cause the full fetal alcohol syndrome face. And maybe she never drank any more after that because she found out she was pregnant. This is really a big problem for our country because nobody's telling women about this. Again, this is one of the embryos that Dr. Sulik had harvested after 12 hours following an exposure of what would be equivalent in the human to 4 to 5 servings of alcohol. And the areas of cell death are shown in the dark blue stain, and that translates to midline defects in the brain. So understanding what neurodevelopmental disorder associated with prenatal alcohol exposure is all about understanding midline defects, but also deep areas of the limbic region that have been exposed that then go on to cause the child to have lifelong problems controlling their emotions and really organizing their thoughts in ways that, that make sense to the world around them. And out in University of California at San Diego, studies had been done showing that the normal brain compared to a brain with FAS or FASD has these changes that can be seen in some cases on MRI. And if you look at these progressively different brains, you see that this one here, the corpus callosum, is a little bit, it looks like it's been a little bit, is thinner, like almost like there's a little bite taken out of it. And because of where my, oh, I can move it. Okay, never mind. I couldn't see this one to be able to show you, but you see the third picture. This is a normal brain. The second one shows the thinner corpus callosum and deeper grooves and pits to the sulci and gyri of the cortex. This third one shows the prefrontal cortex. It looks like you took an egg beater to it and that their corpus callosum is almost not there. That's called partial agenesis of the corpus callosum. And in this case, this one is, the fourth one is total agenesis of the corpus callosum. It means they're missing a corpus callosum. Then the next slide really shows that this child has holoprosencephaly, and each and every one of these 4 were prenatally exposed to alcohol. And these are going to be really early binge exposures because they affected the deeper parts of the brain when the brain was still open to the environment, like I showed you before. Now, that said, Another group up in Canada has done work looking at the wiring. So what I showed you before was what you would see on an MRI. What you see here are more SPECT scans or PET scans of the brain and how the wiring changes during adolescence. So you see these blue neuronal fibers, which are basically just biological wires that are being laid down during adolescence. And in order for all this architecture to occur, you have to have, previous to this, during early development, you have to have little cells making the architecture of the brain that eventually these neurons will expand out into. So everything from going to the higher levels of the cortical function from these deeper areas of the limbic regions to the prefrontal cortex you see right here. And do you see how the red wires are connecting to the prefrontal cortex? And then you have these wires that are going back to the optic center of the brain at the back of the brain. So if you notice on this next slide, you see areas of these wires that are cut as though the wires didn't make them make it to where they were supposed to go. And whereas they're supposed to be connecting to the prefrontal cortex here, they're flipping back and going back into the limbic region. So why that's important to this condition, and I'm about to show you all of the diagnostic criteria. Why these things are important is there is a biological basis for ND-PAE, and it goes back to wiring. And very often, like recently we were writing a paper, myself and Mansfield Mela and a number of other physicians who are looking at this condition and trying to develop a treatment algorithm. We just got our paper accepted for publication, which is a really big deal. But in writing our paper, we described this as a wiring issue, not as a neurotransmitter issue. And many of the drugs used to treat this condition are used to treat neurotransmitter problems. So dopamine problems, serotonin problems, norepinephrine problems. However, if you don't have the wiring going to where you're supposed to, and I write about this a lot in my book, it's like having a 1953 house, which I currently live in, and having the wiring going for the big appliances into the bathroom, not into the kitchen. And in your brain, it's like having the wires wired up to the wrong place. And so we can be giving these kids, you know, X number of antipsychotics until we are just running out of antipsychotics in the pharmacies. And it's still not going to help solve the problem. We might have them drooling out the side of their mouth and having akathisia and catatonia, but we're not solving the problem because it's a wiring issue. So you can look up, you know, these studies that other people have done to see that what I'm talking about is true. That, you know, in fact, as they get older, when they go into fight or flight in these deeper areas, their amygdala is pushed. Instead of being able to take it to higher level brain functions and say, you know, that's not a saber-toothed tiger, that's my mom coming in to say goodnight, or that's not a saber-toothed tiger, that's my teacher bringing over a test paper that I think maybe I did poorly on. These children have heightened stress response and they go into fight or flight and they can't take it to these higher levels like I'd shown you here. Do you see that image? Because they don't have the wiring there. And they can't inhibit their impulse because they don't have the inhibitory controls here in the prefrontal cortex. So instead, they're taking it all the way back. And some of them, if you notice in this next slide, it may be that they will have auditory or visual hallucinations. In this case, visual, because their wiring is now connecting back here to the visual cortex. And when we talk about chronic and persistent mental illness in these kids, again, if you look at the overlapping pictures of people with schizophrenia, which I haven't shown here, They've done similar studies, not this same group, but other groups, with people who have schizophrenia, showing how their brain wiring is misconnected to the auditory and visual cortex. And this is an example in FASD how that can happen. Now, that said, looking at all the way back to when I did my Master's of Public Health thesis, this was in 93 to 94, before we even had the Adverse Childhood Experiences study published. I was looking at children who witnessed and experienced abuse and who had neurodevelopmental disorders in the juvenile justice system, because I was told by Tom Danick at North Carolina, he was at that time head of administrative office of the courts for the training schools. And he said, Susan, you're going to find these kids in training schools and detention centers. I said, well, if you know that, then why don't you do something about it? But having said that, he was in his job and he was doing his job, I guess. But these kids are not resilient. So if you look at kids who witness or experience abuse, you look at kids with neurodevelopmental disorders, they're not resilient. Many of them have negative psychosocial outcomes. Many of them are recidivist and or violent, seen as violent juvenile delinquents. I happen to say they have underlying neurodevelopmental problems, and we need to start identifying those. But as a whole, children with prenatal alcohol exposure, many of them are going to come from families where abuse and violence are common, and even in communities where abuse and violence are common. And you can see that in all of these communities who are having very high problems, social determinants of health. All of these things are interrelated. They witness or experience abuse, and they have these underlying neurodevelopmental problems, and they go on to have, many different levels of trauma-related outcomes. Now, it's not as easy as putting together these little Venn diagrams and showing that, but that's what I did all the way back in 93 to 95, just to be able to write a public health policy paper, which the Governor's Institute on Alcohol and Substance Abuse back then for North Carolina had awarded me a public policy grant to kind of look at formulating some things for the state. I don't know whatever happened with that, but I'm just telling you that this was what I was talking about all the way back in the 90s. And now they're just coming up with the ACEs. I actually have reframed this to show ACEs, but a lot of these kids you're seeing are going to fall into this category. Now, why is it that we ended up needing to come up with a term like ND-PAE? Well, that's because the nomenclature has changed so many different times. Psychiatrists, pediatricians, nobody can keep up with the nomenclature. It changes so fast. And I say it's like an alphabet soup of diagnoses, but they're not really diagnoses. The only thing that you use as a diagnosis from the 1996 Institute of Medicine report is fetal alcohol syndrome, because the partial fetal alcohol syndrome, really you have to know whether or not the mom used, and these alcohol-related effects, alcohol-related birth defects, which are more the physical malformations and ARND, they never were diagnostic criteria in and of themselves. Neither was really partial FAS, although some people do use it. Now, Q86.0 in ICD-10 is toxic exposure to alcohol in utero. And if you do know it, then that's the same as full FAS. So, again, prenatal alcohol exposure does cause birth defects. It also is the leading non-genetic cause of intellectual disability disorder. And we do believe it accounts for much of the chronic and persistent mental illness that we have. Now, that said, fetal alcohol syndrome is somewhat protective for children. So we've known for a long time that if you get the diagnosis of full fetal alcohol syndrome, and again, a lot of these kids look dysmorphic. A lot of them look like other conditions like Down syndrome or Fragile X or Prader-Willi. Like, they look different. If you have a child who gets the diagnosis of FAS from age about 5 or by age 5, they are protected in a way from having more severe problems later. And their prognosis is way better because they get supports put in place early on versus the children who are not identified by age 5. And I happen to think that it's not just the fetal alcohol syndrome. I think if we were identifying more of these children from age 0 to 3 and having the proper supports put in place and telling the adoptive families, this is what your child has, it's kind of like a child who has Down syndrome. They're going to do way better than if you adopt them into these families and you don't tell them they were prenatally exposed. They're going to end up with poor prognoses because the family doesn't know what they're dealing with. With the full fetal alcohol syndrome, of course, there's the facial features, the growth deficiency, and the neurodevelopmental deficits. And if you have this and then you do a genetic test and you determine that these things are not caused by genetic disorders, you really don't have to know whether or not the mother used alcohol, as long as they have the characteristic facial features, growth deficiency, and then neurodevelopmental deficits. I'm not going to speak a whole lot about FAS because these babies are pretty easy to identify either at birth, in toddlerhood, or before adolescence. And again, it's a smaller than expected lip, thinner, kind of indistinct philtrum, and small, wide set eyes. Those are the 3 predominant characteristics. You can also see the nose being a little bit short and upturned. Like this little boy looks like his nose, the tip has been, kind of pinched off. You see that his nose looks like it's kind of pushed in a little bit. You can clearly see his eyes are, the palpebral fissures are a little bit foreshortened. In many cases, what you want to do is you want to measure between the eye openings, and you want to have one eye exactly that fits in between the eye openings. Now, you can clearly see this little boy has more than one eye distance in between the eyes, and it goes down to the millimeter. You want to measure the distance between the palpebral fissures, and when they have their eyes open, not necessarily like that, but like from here to here, and then you want to have only one eye distance in between, and you can clearly see there's more. Now, as the face matures in adolescence, you're going to see a difference. Now, even these kids are not being properly diagnosed. Even the ones with full fetal alcohol syndrome, people are not properly diagnosing. And they'll walk every day of the week into a psychiatrist's office or a pediatrician's office and not be diagnosed. And the parent will start talking about behavior problems, and someone will pop them on ADHD medicines without really fully doing a thorough history and finding out that this is a problem. And that's, in my belief, why many of these kids end up going on to have chronic and persistent mental illness, because nobody's adequately diagnosing their neurodevelopmental problems. That said, I believe that the face doesn't really matter unless you're a plastic surgeon and you can do anything about it, other than predicting some of the children who have even worse effects. It's actually a better prognosis to have the full fetal alcohol syndrome. So to have the face is a better prognosis. Now, that said, I had already told you about the early FASD diagnosis being better. And really that's because people have a better understanding of differences today that they can see. So if they see a child who has Downs, or they see somebody who looks kind of like Downs or kind of like autism, they're going to be a little bit more easily accepted into the world. The school system will have a better tolerance and a better approach to dealing with them. And the parent can overcome their grieving, and really become a little bit more hopeful about helping the child when they know what the diagnosis is. But that's why I think there's hope with us understanding ND-PAE as a diagnosis, because I think then we can start teaching parents that, hey, there is a way to work with these children that will help predict a better outcome for them. Again, there's reasons for diagnosing this that have to do with medication response, safety issues, involving medications and many other reasons that if we could embrace it, it would be better. So we're going to jump now into, and I'm going to just take a pause. We're about to really get going. Remember how I said I'm slow to warm up, but with that background, I gave you kind of like the background that you're going to be able to just go right into what this problem is. Okay, this is my hope. So when we take apart what we did with DSM-5 back in the day, now DSM-5 sits on my, right here, on my desk almost all the time. And when it's not here, it's right up on the shelf where I can reach it. Because almost every disorder in childhood, what we used to call the childhood mental disorders, you can find in these children. The other thing is many of the adult disorders you can find in the adolescents and adults who have this condition. But if we start to reframe it in the ways that DSM-5 is pointing to, then I think we will have we will do better at making these children less complex, okay? And make it easier for parents and caregivers and society really to understand and help them. So that is the condition that's right now identified on page 86 in DSM-5, and that is using the code F88, specified other neurodevelopmental disorder. It is neurodevelopmental disorder associated with prenatal alcohol exposure. And all it says in the front very succinctly is it's characterized by a range of developmental disabilities following exposure to alcohol in utero. What I've heard that they're doing in places like Europe and Canada is they're using F88, where these are children who are too young to really to know whether they fit the full criteria for ND-PAE, but you do know that they were exposed, okay? And maybe they don't have the face at that young age. Now, in my view, you should flag those kids and say, yes, they need following ongoing from early ages. And we can probably say they have it because we know the mother did use and the birth dad was a chronic user. Therefore, the epigenetic effects combined with the prenatal exposures, and in fact, the epigenetic effects alone account for about 75% of what we know as the fetal alcohol spectrum disorder. So these kids are going to be at much higher risk of having this problem manifesting as they go on into adulthood. So in the back of DSM-5, there are criteria that are up under neurobehavioral disorder associated with prenatal alcohol exposure. DSM-5 has gone through already since 2013 many different iterations, meaning, you know, almost every, few months, there are new adaptations to have been made. And therefore, we were able to clarify the nomenclature. And a lot of people in the FASD world do not know this, but we went back through an action paper and clarified that the back of the book, the criteria that are listed in conditions for further study are the same as what we were pointing to in the front as neurodevelopmental disorder associated with prenatal alcohol exposure. I'm not going to go into the nomenclature. I'm not going to fist fight the people. I don't have the time for that, who call it neurobehavioral disorder. If it's a neurobehavioral condition, that really isn't even according to what DSM-5 is all about. Remember, neurodevelopmental disorders are what are in the front of the book. They reframed all the childhood mental disorders as neurodevelopmental. So therefore, it doesn't make sense to call it neurobehavioral, right? Because remember, and I'm showing you this, neurodevelopmental disorders, these are all neurodevelopmental disorders, okay? This is how DSM-5 is reframed, okay? So this neurobehavioral disorder is really neurodevelopmental disorder associated with prenatal alcohol exposure. And these are the criteria, and that's what I had sent out to Barb to send out to you guys, which I have put into a screening tool. So these are not necessarily, I call it a screening tool. You could call it a diagnostic tool, but what you want to do is you want to see, does this child have these conditions. So when you look at, do they have more than minimal exposure to alcohol during gestation? Well, what does more than minimal mean? In DSM-5, they characterized it as at least 2 drinks at any point in pregnancy. So if she's willing to admit that she drank 2 drinks even prior to pregnancy recognition, why 2? Do we think that 2 drinks are enough? Well, in fact, for an Asian woman in the late 3rd to early 4th week, it may be that 2 drinks are enough, because many Asian women lack the, actually they have a variant of alcohol dehydrogenase enzyme that makes 2 drinks seem like 4, okay? And I have seen individuals, at least one individual in my practice whose mom is a biological physicist or something like that for one of the National Institutes of Health, and drank 2 drinks a day for the first 9 weeks of pregnancy until she found out she was pregnant. And this was while she was in graduate school. She had an unplanned pregnancy with a then medical student, and they went on to have this son who had tremendous problems. She was Chinese, and the father was also Chinese. Now, having said that, is anybody telling people this? No. Well, why is that? That's a problem, right? And so if you have children being adopted from Southeast Asia, you need to look at them as maybe having even a higher risk of this problem if they're ending up needing psychiatric care. So it's not just the more than minimal exposure to alcohol. If let's say they're adopted, and you know that they were adopted because at age 6 weeks or 6 months, the birth mom was found unresponsive and not taking care of the child and neglectful, you can better believe it that she was probably drinking during the pregnancy if she's, you know, that drunk. Or let's say the child is 3 and the birth mom died after 9 pregnancies of cirrhosis of the liver. Well, you know, that right there is enough to say that the child at age 3 was probably prenatally exposed to alcohol if they have a mother dying of alcoholic cirrhosis. So when people say this is really hard for us to know if the child was prenatally exposed, well, why is it so hard to know if we have all these factors pointing to that? Now, that said, do they have impaired neurocognitive functioning? They only have to have one of these 5. So they have to have at least one of these. Now, this where it says IQ of 70 or below, actually IQ of 75 or below is now the new DSM-5 criteria for intellectual disability disorder. So this number 1, do they have an IQ of 75 or below? That's the way it should read. Although in DSM-5, this criteria was done at the same time IDD was being reformulated. So just so you know, they only have to have one of these. Do they have executive functioning issues? Do they have learning disabilities? Do they have memory impairment, visual spatial reasoning? They only have to have one of these. Then the one for self-regulation, they have to have at least one of these: mood or behavioral regulation problems, attention deficit, impulse control problems. Now, in a little child, I'm about to show you some of the things after I do this. I'm going to show you some of the things in little children, because you wouldn't have done, let's say, a neuropsychological testing yet, and you wouldn't see, do they have any impairments in these areas? Because this really requires neuropsychological testing. Sometimes what you will see in younger children is communication deficits, so that is where their acquisition of language is later, or social communication and social interaction problems. And you have to have at least one of these 2 things. You have to have at least one being either communication deficit or social communication and interaction. And this right here, this social communication and interaction, looks a lot like what's called social communication, in parentheses, pragmatics disorder, which used to be Asperger's disorder, okay? This problem right here is where they don't have any social communication problem, or they don't have any communication problems, that is language problems. They just have these problems understanding nonverbal cues, facial expressions, body language, that type of thing. And if you look at the criteria for social communication disorder in DSM-5, which is what used to be Asperger's, a lot of these kids have that. So 2 or more of these impairments in what they call adaptive functioning, although this isn't really, it doesn't line up with what are adaptive functions according to IDD, and I'm going to explain that in a minute. But daily living skills and then the motor skills being another problem. What is missing from these criteria here, which really a majority of these kids have, is sensory integration problems. And another problem called interoception. So the ability to understand how their bodies are giving them signals that mean they're hungry, tired, sleepy, need to go to the bathroom, you know, all of these other functions that your body gives you, these signals, they have a harder time with. And because of that, they look like they're going into mood dysregulation, autonomic arousal. They look like they're going into a rage, and the parents can't figure out why they are. And a lot of it is because they're not accurately perceiving the signals they're getting from their body. Now, that said, this next thing, impaired self-regulation. The parents can see this from a young age, and almost a majority of the children I see in my practice from age 2 or 3, they were having fits like nobody's business. Now, a lot of this goes back to what's called disruptive mood dysregulation disorder. And again, what I told you before is you can get almost every diagnosis in DSM-5 from prenatal alcohol exposure. And if you superimpose on top of that, witnessing or experienced abuse, and on top of that, alcohol and other drug abuse during early adolescence, you're going to find that you can get almost every diagnosis in DSM-5. Now, that said, these self-regulation problems, mood or behavioral regulation, attention deficit, or impulse control issues. So impulsivity, a lot of these kids look like they have ADHD because they're so impulsive. Again, we had talked before about attention problems, and those are in here under, yes, under that same category, the self-regulation. And I apologize, when I went through these before, I shared with you about neurocognitive, and then I didn't share about self-regulation. But many of these kids, as I said, from say age 2 or 3, they will go into heightened stress response, and almost with seemingly no provocation, they will get upset. But if I go back as a psychiatrist and I look at what happened during those episodes, it could be as simple as neutral face, parent presenting neutral face. Now, what does neutral face look like? That's neutral face. So the kids need constant reassurance that everything's okay, because on the inside of their brain, they can't tell in the environment that everything's okay. So everything's okay, everything's going to be okay. You know, they need that from the parent. And if the parent's constantly reassuring them, hey, everything's okay, everything's going to be okay, I got this, we got this, we're in this together, you know, happy face, optimistic. I always say that I don't like to say this because I think there's a perfect way of parenting, but there is a good enough way of parenting for every single child. And it's a different type of parenting for a lot of children. So these children need optimism, they need hope, they need people around them giving them support, encouragement. They don't need people yelling, they don't need people raising their voices. And a lot of that goes back to they are unable to self-regulate on their own, and they need an external person or external people to help them with that regulation. So some of my my ways of working with families I'm going to share in just a minute really go back to that. Teaching parents even. I have one mom in my practice who's really lovely. She's a social worker, and she actually works for our local county social services. And she has learned herself that her own autonomic arousal, her own anxiety causes her a lot of times to kind of look like a deer in headlights when her child is coming at her with such rage. And so she'll go, and that scares him. Or she'll look at him neutral face. And to her, it doesn't look like angry face, but to him, he picks up angry face. Because remember, these kids have social communication problems. They don't accurately perceive facial expressions. So that said, just putting these things together, actually Sarah Matson out at ACAP in San Diego, when she and I spoke together back in 2014, I did an all-day institute. I chaired an all-day institute at the ACAP, American Academy of Child and Adolescent Psychiatry. Sarah Matson from San Diego State University Center for Neurobehavioral Teratology spoke, and this was one of her slides that I've kind of redone a little bit to compare to IDD, okay? So if you look at ND-PAE compared to IDD, and I'm going to show you IDD in a second, you've got the neurocognitive piece. This is just reframing what I just told you. You have the neurocognitive piece, the self-regulation piece, and then the, and I'm having to, I can't see all my slides all at one time, but you have this last piece, which is adaptive functions. Now in IDD, all of these three things are considered adaptive functions. And really, most of the children that I've ever seen with ND-PAE have adaptive functioning deficits. This isn't just what I've seen across the country. That's why we advise anyone who has this condition to have a Vineland or an ABAS. And I believe that they all also need an ADOS, which identifies whether or not they would have autism. Okay, and I sent you a paper on the clinical link between autism and Asperger's that's in an international book on autism from 2013. I sent that to Barb, and she should forward that over to everyone. So conceptual skills, social skills, and then practical skills. And in my belief, these things are way more important to these individuals with FASD than, you know, let's say learning differential equations when they're in second grade, which I find that school systems now are encouraging parents to teach children, you know, at those ages. Like kindergarten, they have to know all their basic math facts. Well, no, what's more important is, do they accurately perceive social cues? Are they knowing how to wipe their bottom and, you know, have good hygiene and self-care? And do they know how to do household chores? And can they cook for themselves? Can they start learning basic life skills? And I'm not saying by kindergarten to be able to cook a 10-course meal, but they should know how to take care of themselves. And it's these reasons, these adaptive functioning deficits, that lead these individuals to fall off the cliff when they go into transition years during adolescence and not be able to manifest adulthood because they don't have adaptive functions to the level that they should. So now again, I'm showing you these things for IDD because when states look at who has developmental disabilities and who does not, they look at adaptive functions to determine developmental disability eligibility. And so with ND-PAE, already you know that they have a developmental condition that affects their mental capacity that is not a mental health problem. So that's number one, usually required for most states for developmental disability assessment. Number two is they have to have adaptive functioning deficits. And most of these individuals, from what I've seen, have adaptive functioning deficits where they would qualify for a developmental disability because most of their adaptive functions are at or below 75, even though their number is at or above 75. And why this is important, is that, you know, it's no longer the number. According to DSM-5, the number is not as important. The number that you get on your IQ is not as important as your adaptive functions. So these adaptive functions are like really important for parents to understand and to start helping the child develop from early ages, to know how to dress themselves, to know how to dress for the weather, to know how to brush their teeth, to you know, keep their room tidy, to, you know, get up every day and make their bed. There's certain things that if you sort of begin at very early ages teaching children, they can develop a higher level of functioning than if they were just required to do math, which is more conceptual. See, these conceptual skills are going to be harder for them. So learning the math facts, learning to tell time, money management, all of these things are going to be harder for them. So it's important to work on some of these other areas so that they can feel accomplished in, let's say, more practical areas, even though it's going to take longer for them to develop those as well. But to function in life, you need to be able to take care of yourself. And that's very often why these children end up institutionalized, even when they are brought into the best meaning, well-intentioned families who are taking care of them. It's because they're pushing them through the rigors of academics when academics isn't really their forte. They would be better off, you know, learning some practical things and job-related skills. I'm not saying in kindergarten, but, you know, they need to be able to have meaning and purpose in their life. So getting back to what I have written a lot about and spoken a lot about, I think to look at these children in 4 domains is a better approach. Not saying to dismiss what's in DSM-5, we at least now have a way to approach diagnosis. But in terms of treatment, to look at adaptive functioning in these multiple domains. And some kids are going to be better than others. Like I have some kids in my practice that don't necessarily have emotional outbursts, and they're typically the ones whose neurocognitive functions are way, way lower. So they are by definition intellectually disabled. Their functioning is really low, and they don't have the emotional outbursts that some do. Or it may be that the parents are interacting with them a little bit differently and not really expecting very much of them because they know they function at a much lower level. That said, the social communication problems that a lot of these kids have, social perception, social language, you know, these are really nonverbal ways of interacting. And some of them are verbal. So even, you know, auditory processing, when you're listening to someone who's chatting with you. And Barb, it looks like you want to say something.
I was just going to say, after this slide, could we do like about a 5-minute break or 7-minute break for everybody?
Sure, I'm happy to do that.
I forgot to remind you that that was something we had told them we would do. Thank you.
That's okay. Thank you, Barb.
Yep.
I appreciate. Am I going okay, or do you want me to speed up?
Yeah. No, it's good.
Okay, perfect. So, so what I'd like to do is just give you the overview, take a 5-minute break, and then we will go from there. So I'm going to go deeper. I'm going to dive deeper into this, but with these subsequent slides. So social communication is your social intellect. You've heard of social intelligence, right? You've heard of emotional intelligence being your emotional regulation piece. That's mood dysregulation, autonomic arousal. The neurocognitive is really what we think of as our intellect, but it also includes executive functioning issues, which a lot of these kids have. And then sensory and motor. And whereas I talked before about your the sensory integration piece, which is missing for the DSM-5 diagnoses, the other piece is interoception. And we're going to dive a little bit into that because I think if parents better understand what is meant by interoception, that's our 7th sense, with the 6th being proprioception, the 7th sense being interoception. If we had a better understanding of that, we would be more tolerant of the children and really understand where they're coming from when they do go into one of these emotional outbursts. So thank you so much for this time earlier. I'll be back on whenever you guys are ready to check back in.
All right, let's say we'll be back on at 11:20. All right, have a nice break, everybody. And okay, we're back after our break. So I just want to remind people that you guys can also put a little message in the chat box. If you have a question, put it in the chat box. If we have time, we'll get to them. And if we don't, we will try to get the answers and follow up with email with the answers. So back to Dr. Rich.
So I'm just going to breeze through the next part of this. So neurocognitive, this is your cognitive functions, your executive functions, working memory, processing speed. You know, these kids have a hard time with consequential thinking, filing, scheduling, bookkeeping, time management. They're gullible, easily led and influenced by peers. That's why people in the FASD world are saying they need an external brain, okay? Next piece is social communication and social perception. This is why, going back to what we talked about before, very often they are seen to have expressive and receptive language problems, social skills deficits, not understanding social reciprocity, and speech and language pragmatics. They're not cognitively flexible. They're inflexible. They have a very difficult time with transitions. The emotional intelligence relates to their mood regulation, autonomic arousal. They go into fight, flight, or freeze very easily triggered and provoked into that aspect of the brain, which I take back to the fainting goat that has a myoclonic seizure when it becomes aroused, autonomically aroused. I call these limbic seizures because it's almost like their limbic region is hijacked and hijacks the rest of their body. Now I do happen to have goats. I now have 14. I just brought back 2 baby goats, one that his mother had rejected because I'm developing a therapeutic farm for these children. And I do have 1 fainting goat. So I do understand a lot about how myoclonic seizures work, and these children do go into these limbic seizures, and we'll get into how we can treat that in a bit. But sensory and motor I had talked about already, and so, you know, hypo and hypersensitivities to various different things, and their kinesthetic abilities. Some of them have really good gross motor skills, so they might do fine in recreational activities, playing sports, and that type of thing. They might have pretty good coordination and balance, but they may have difficulty with fine motor skills, or they may have had problems with oral motor as children. Some of them love physical contact, and they tumble and they roughhouse and they get bruises, and you never even know how they got them, because when you ask them, how did you get those bruises? They say, I have no idea, because they don't feel pain at that level. And again, a lot of this goes back to their sensory issues, and how their nerves are not wired properly to certain parts of their skin or their muscles, and that they're not feeling when they get hurt. Now, we talked before about the 7 senses. So, you know, the first 5, and those are feeling or hearing, smelling, tasting, touching, seeing. And then you have proprioception, which is the 6th, and the 7th is interoception. So we're gonna go from there in a few minutes. Now we have ND-PAE, and commonly you can see this even before you can diagnose it, but the diagnosis usually occurs after you can do the neuropsychology examination. So you get a neuropsychologist to look at them. You can see some of these things, and even as a psychiatrist, we could probably diagnose it without the neuropsychology testing, but it's really better to have the neuropsychology testing to be able to make the full diagnosis. of ND-PAE. You can see in young children a developmental history with deficits in a lot of the developmental milestones, and in toddlers. Many of them, they may talk a lot, but it really either doesn't make sense what they're saying, or their receptive language is much, much lower than their expressive language. Many of them look more like they might have autism, high functioning autism, or what used to be called Asperger's, because they prefer playing alone or just with a few friends. And some, as Dr. Ann Strythguth once said, look like they have a cocktail party personality. So they actually look like indiscriminate attachment. In children, you see a lot of attention deficits, and studies have shown even as little as 1 drink a day throughout the pregnancy can lead to attention deficits, hypersensitivities, heightened stress response, poor problem-solving skills, decreased memory, limited ability for abstract thinking, failure to understand consequences, misperception of social cues. All of these things can be seen in these kids. And again, in children, they can manifest in so many different ways that helping parents understand that it's not just the, the things that we can put our finger on, like learning disabilities and having trouble with math or learning time or reading, but some of these other issues that are impacted. And these are functional birth defects. That's something to think about. Now, that said, when you are evaluating your clients, and I understand that many of you are clinicians who work with clients who may have been adopted. We here in Maryland have the Center for Adoption Support and Education, which has a national training initiative for adoption and mental health competency in child welfare workers. And that's really available nationally as a free material developed by, I think, HHS. It was funded through HHS. You should be asking them, is there a chance the child was prenatally exposed to alcohol, even before the mom found out she was pregnant? There are ways of finding that out, even if the child is adopted. You can go back and you can find the birth mom and ask and make it a non-judgmental thing, or you can look back through the adoption records and figure out, what was this child taken away because of an underlying alcohol or substance use problem. If they are adopted in foster care, kinship care, or orphaned, they're at much higher risk of having this condition. And the other question is, does the biological mom, like I said, have any underlying alcohol problem? If the pregnancy was unplanned or mistimed, then, and the mother, the birth mom, was using substances, then you also have a better way of understanding that. And then on my questionnaires that I ask, that I provide to all patients, I have like maybe a 9-page questionnaire that gets sent out to all patients before they come in to see me. I have a variety of questions listed, and one of them is, were there, how many cigarettes were there, packs per day before, during, and after the pregnancy? Did the father smoke any? How much beer, wine, or liquor? You're not asking, did they drink? You're asking how much was there? And what about while breastfeeding? And what about the father? Was there any inadvertent binge use? Again, before the mother might have known she was pregnant. How many other drugs did the mom use? So again, if the child is adopted or in foster care or kinship care, you may or may not know, but you'd be surprised how much you can find from some of these records. I've even had parents who have adopted children from Russia who go back and they get a private detective who, some of these private detectives are actually attorneys who go and meet with the birth family, and they will interview people in the birth family to find out. And I know that's not always possible here in the States with foster care in that setting, but it is something to think about. And again, you know, all of these factors come into play, not just prenatal alcohol exposure, but, you know, unintended pregnancies, if there was heavy paternal use, the age of the mother, and parity. So how many other pregnancies did she have? Is her body maybe not as healthy as a young woman who's in her late teens that may not be in the advanced stages of her alcohol abuse yet? What's the timing, frequency, and duration of the exposure? Were there other substances used? So problems like cocaine abuse at the same time with alcohol, it creates something called cocaethylene in the mother's liver that then is a highly neurotoxic byproduct that does go through the placenta, whereas cocaine itself, even studies back at Duke all the way in the late 80s showed that the women who are only using cocaine, their babies don't end up with the severe neurodevelopmental problems that the babies with fetal alcohol syndrome or cocaethylene have. And then what was her nutrition? A lot of studies in Minnesota and other places are showing that choline supplementation, 500 milligrams twice a day, can be really helpful, neuroprotective. That, you know, many of the multivitamins that are marketed as prenatal vitamins, Dr. Carl Bell out in Chicago showed that, you know, almost none of the prenatal vitamins had adequate amounts of choline to actually help the baby's neurodevelopment, or even omega-3 fatty acids. So that's another thing to keep in mind. And did the mother, was she exposed to domestic abuse or having her own heightened stress response during the pregnancy? And with this global pandemic we're looking at right now, in addition to people drinking more and being at home more, so around their spouses, where there's higher rates of domestic abuse, people are also experiencing, you know, really international movement that is causing much chaos around, you know, the social determinants of health and racial inequity, which children are experiencing and pregnant women are experiencing. So I do believe for all of these reasons, we're going to see another uptick in the numbers of children who are prenatally exposed for that reason. Now, that said, an international consortium got together a while back, all the way starting in 2016, I believe it was, and we began developing a way of looking at these children for what treatment algorithm would we use to help in their psychiatric medications. And what we looked at is 2 domains of these 4, one being emotional regulation, hyperarousal, and mood dysregulation, and another being neurocognitive, hyperactive, and cognitive inflexibility to be treating. And that paper is upcoming. It was finally, you know, we've finally been able to get it published now, almost 4 years later. But we've met several times as an international team and come up with this algorithm. So that said, if we look at what we're actually treating, if you notice that in the communication realm, you need a speech and language person working with the child. In the neurocognitive realm, you can use some medications, but also helping the parent think about being an external brain for the child. In the emotional regulation piece, again, you got to get them sleeping well. You got to dampen down that 0 to 60 stress response. You know, when they are volatile and have that low flash point, you have to figure out what it is that's causing their disruptive moods. Don't just think, oh, you know, they're acting, you know, the way that they do because of something that you can't pinpoint. Usually you can pinpoint what's causing it. And sometimes it's the way that people look at them and their facial expressions that cause them to become dysregulated. Sometimes it's because they're sleepy or they're hungry or they're tired, or They don't understand they need to go to the bathroom. Their tummy hurts, but it's actually because they need to go to the bathroom, or their tummy hurts because they're hungry, and because of interoceptive problems, they can't pick up on that. The other piece is the hypersensitivity. So the sensory piece, and not being able to totally, appreciate the fact that, maybe they're hot because they have on a jacket and they need to take the jacket off. So they're not hot and grumpy. Or maybe it's because there's a tag in the back of their shirt that's bothering them, but they can't tell you that this tag is bothering them because they're not adequately picking up and processing the signals from their body because of these interoceptive problems. So getting back to the social communication problems and the mood dysregulation problems, these children have problems articulating their emotions. They don't have the right words, and they don't, because their facial muscles often aren't innervated the right way. They don't make a wide range of facial expressions sometimes. And because they don't make the wide range of facial expressions, or they didn't have the inputs coming from caregivers in an early age because they were in orphanages or in multiple foster homes, they didn't adequately attune and attach to someone to be able to make proper mirroring facial expressions. And so often they're misunderstood as being callous or unemotional. They appear just, ambivalent to what's going on around them. Sometimes it's because they've had a trauma history and they're just totally detached from what's going on around them because of that. And then as a result of this, processing problem, processing emotions, they shunt arousal into their endocrine and autonomic nervous systems. And when we look at why it is that many of these children end up with immune function problems, it's because they're under heightened stress response a lot of the times, and they're inaccurately shunting a lot of their arousal into these other areas of the body. So I'm gonna go on. I've been talking about this already, and I already spoke about why mental illness, so much mental illness exists in these kids. And then the 4-domain model, I talk a lot more about in the paper that I sent you. So I'm not going to spend a huge amount of time on this because we're at 11:40 now, and I want to leave some time for questions. But again, almost every diagnosis, including a lot of the personality disorders, can be seen in this. And again, just as an overview, these kids have heightened stress response. Their amygdala, which is the little red button there, goes off. They go into fight or flight, and it's almost like a limbic seizure. That's what I had talked to you about before. And in that case, the signals are going down into their gut and other systems of their body. All of these wires through the vagal connections, through the somatosensory connections, are going down and really triggering problems in other areas of their body, and vice versa. Many signals, about 90% of your signals, are actually coming from your body going up. And that said, this couple of videos I'm not going to show because it would take too long, but they're on the documentary that I mentioned, Dispelling Myths About Alcohol-Related Birth Defects. So Barb and Kate had said that it's okay for me to upload this to my YouTube channel. I have that documentary on the YouTube channel. If you just put in your Google search, Dispelling Myths About Alcohol-Related Birth Defects, it was a CDC-funded documentary that we did is produced and published in 2001. It's still very much accurate. CDC is in it. Many experts around the country, including Dr. Ken Jones, who's a co-author in the first paper on FAS, Ed Riley and Sarah Matson out of University or San Diego State University, many people, and Mary Schneider, who actually, her work is at the Harry Harlow Institute on prenatally exposed monkeys that had the equivalent of 1 drink a day throughout the pregnancy. And that's what this shows. I'm not going to go into that, but these maladaptive attachment behaviors happen in the womb, and the babies end up with problems lifelong because of the way their brains are wired and not being able to adequately attach to their parents. And that's what a lot of these children end up with, is faulty attachment. And it's very frustrating to parents, but if they can understand it's a neurodevelopmental wiring issue, that will help them. So I'm not going to show you this, but now hyper and hyposensitivities, I'm going to tell you about the seventh sense just really quickly. So I told you about the first 5 senses, which can be affected. Proprioception can also, but interoception, these are the signals they're getting from their body. And I talked about that a little bit ago. And again, these executive functions, if I had to pick 2 things to help parents understand, one would be interoception, the other would be executive functions, because I think these 2 things are very frustrating to parents. And they seem to think that the child is coming out of nowhere, you know, with their mood outbursts, and they're not really coming from nowhere. It's just the parent doesn't understand. And so therefore the child, many of these children end up with chronic mental health problems. But if we were to take a step back and start identifying more of these children younger and putting systems in place, it would really help. And a lot of these secondary disabilities would be prevented. So in a nutshell, what we need to do more of is cocooning these kids from cocooning them from harm. And when I say that, it means creating systems that are very much like what we're doing now with coronavirus, like keeping their world small, okay? And not letting them out and running wild on the streets, so to speak, for predatory behavior of other people to get them using alcohol, tobacco, other drugs, okay? We talked about the medications a little bit. There is the other thing to write down, and I didn't send you yet, Barb, but if you'll get back with me and say, Susan, what were the 2 things you told me? I will send you these 2 links. So this one is Elizabeth H., and she talks about her history of having been adopted from Russia at the age of 5. She is not my patient, but she is from here, and her dad is the board chair of my board, Ralph Hitchens, and she's never been my patient. But she talks about her story, and she actually came to ACAP in 2014 when I did the All Day Institute, and she gave a talk on her, what had happened with her. And she's 4'9", has FAS, was really diagnosed very early on, but the doctor who diagnosed her didn't tell her parents that there was anything to do about it. And this was the big problem. And I won't go into detail about her story, but if you'll look up Elizabeth H. FASD on YouTube, just put in Elizabeth H. like Harry or Hitchens, Elizabeth H. YouTube. It tells all about her, okay? And she actually, that's her YouTube. It's like a 5-minute thing that she tells. So I think we need to rethink foster care and parenting. We need to cocoon them. We need to find safe, supportive housing for them, and we need to go back to those adaptive functioning issues to help them. So not pushing them through the rigors of a big academic curriculum, but to get practical skills and social skills. And really this model, this steps for resilient, successful child development, it involves having an awareness of these neurodevelopmental problems, and also the child's strengths and interests, and accepting them with realistic expectations for where they're at, and then attunement and attachment to their rhythms from an early age, their vibrations, their frequency, and then helping them to develop their adaptive functions that are geared toward their abilities, as well as helping support their neurodevelopmental problems, and then providing opportunities for them to achieve Maslow's hierarchy of needs, meaning and purpose. A lot of these kids love animals. They, for whatever reason, are totally interested in animals. So get them involved from early ages in care of a neighbor's dog, or, you know, let's say grooming dogs, walking dogs, or go to a local, you know, equine stable and get them involved in not just riding the horses, but helping care for the horses. Because what I found is that so many of them really do use that as a motivation, you know, that they are so interested in these things that they are willing to do what the parents would like them to do because they have these other things that they're doing that make them feel really good. And again, this is another way of looking at the same thing. And these are gears then that help the family run better. So this awareness, this acceptance, attunement, adaptive functioning, and then meaning and purpose allows your child to be more happy, confident, and hopeful. And happy, confident, and hopeful is what we want in children, right? And in adolescents and young adults. That said, there's many different things I could say about this, but I believe in high standards. No alcohol, tobacco, other drugs. No getting in trouble with the law. Working in a trade, vocation, or profession that gives them meaning and purpose. And then graduating high school without getting anybody pregnant or without getting pregnant. These should be our high standards. Instead of the high expectations, you're going on to college or Yale or Harvard. No. Not everybody needs to go on to college. Everybody, though, needs to be a good citizen. And that's what I think would help more of these young people feel good about themselves, to know that they have meaning and purpose and that they are productive and they're able to accomplish things. So that said, I'm going to leave it with the structure of the caregiver and the caregiver environment having some semblance of a scaffolding to help them understand their child. And this isn't the only thing, but it certainly will help. And I think that's why the scaffolding provided for kids with FAS and for families of these children helps the children when they're diagnosed at age 5 or younger, because they have this whole systems approach to help them rather than falling off the cliff with no supports. And it's kind of like, you know, having a rigid or somewhat, you know, stable cocoon versus, you know, a cocoon that's just going to deflate because you don't have the right supports in place. So that said, I would just refer you to, you know, if you have young children that you're not sure, you know, go on the CDC. They have this milestone tracker now, you know, get the parents involved with tracking the milestones. And then, you know, there's publications put out that are free of charge. This one is online, tip 58 through SAMHSA, addressing fetal alcohol spectrum disorders. This one, fetal alcohol syndrome guidelines for diagnosis and referral, was put out by the CDC. We have the Center for Adoption Support and Education has put out a national training initiative on for adoption competency in child welfare workers. That's another good one. I don't have that on this slide, but I can send that to you, Barb, and you can send it out to everyone. You know, I just open it up for questions.
So a question that we have from Kate is that saying that this is really making her think about the importance of a multidisciplinary team needed in treatment. Are there specific aspects of this that you recommend considering treating with medications, psychiatry, etc.?
Yeah, so that goes back to the multidisciplinary approach. And again, I'm a child psychiatrist, so we don't work in a vacuum. We work with a lot of other people. I actually go to educational management team meetings. I do involve extended family, coaches, clergy in understanding this condition. I share with parents that, you know, having a team approach, you could put anybody in the middle here. And this is like a Rubik's Cube that moves around, and it depends on where the child is in their development. Sometimes the person who very first sees them is the geneticist, right? And the geneticist has to pass the baton to somebody else because the geneticist sees a lot of different people. And maybe they would only see the person once a year or once every few years. Whereas a psychiatrist or a developmental pediatrician would see them a little bit more often. In my experience, developmental pediatricians will see somebody every 3 to 6 months. As a psychiatrist, I see them weekly, And again, not everybody can afford that. So I've recently gone into partnership with an agency that takes Medicaid, and I'm actually seeing their patients virtually, but I'm seeing high incidence of this problem amongst these individuals. So you're right. And medication approach, again, I cannot, as a psychiatrist, tell you what medications we're going to use in this population. But a multidisciplinary team includes psychiatrists, but not just for medication management. I think psychiatrists are very key in doing parent guidance. I was trained in the family systems model, and as well as the 0 to 3 model at Children's National Medical Center. I'm a psychotherapist. I do, not just play therapy. I've developed agrotherapy, farm animal assisted therapy for these kids. And I think if more parents could get their kids involved in things like nature and 4-H and those types of things, as well as meditation. So medication and meditation or mindfulness can be very helpful for these kids.
Right.
And thinking about medications like clonidine, which is an alpha adrenergic agonist, over the high potency neuroleptics and antipsychotics, and sticking kids on Ritalin and other forms of stimulants are not the answer. When
Right.
a lot of these kids, it's not a dopamine problem, it's a wiring problem. So that's where I come from with it.
All right. Well, this is wonderful, and I did send Kate the handouts and the links that you sent me this morning, so you'll be able to share those with everybody who's attending, right, Kate? So,
yep. Barb, before you
Yep.
go, there was another question from Kate that I think is a really important one. She is asking if you can give a diagnosis when there's little or no information on the birth parents drinking.
Well, I'll tell you something. A lot of these kids have full FAS. If you take Dr. Ira Chasnoff for what he wrote, that many of the kids with full FAS are not being diagnosed. So if you consider it was bad enough, whatever chaos in the family was bad enough to get the child taken away, then I go back and look at the birth pictures and I look at the early childhood pictures, because those faces are going to be show prominent features versus, earlier. If you can prove full FAS, so the growth retardation, the facial malformations, and the neurodevelopmental problems, then you don't need to know, did the birth mom use? Because by definition, FAS without any genetic causes, so you do a genetic workup and you determine there's no genetic reasons for the dysmorphology and the neurodevelopmental problems and the growth retardation, then they have FAS. So you don't need to know the birth mom's history. If a child in the family has an FAS diagnosis, you don't need to know, because you do have, by virtue of the other child having had FAS, the birth mom used during that pregnancy. So by extrapolation, you can say this unplanned pregnancy, this other 9th unplanned pregnancy most likely was also prenatally exposed. Now, and by my way of working with families, I say, just like every other condition, we can have what's called rule out diagnoses, which means we're saying this is probably what it is, but we don't have evidence. We weren't sitting there. See, a lot of psychiatrists or clinicians, and I'm not bad mouthing them, this is how we're trained. They'll say, well, Susan, we weren't really sitting there at a cocktail party watching the mother drink. Therefore, we cannot say she drank. Well, I think that's a bunch of baloney. Okay. I wasn't there seeing a woman getting raped and molested, or the guy in the Viet Cong getting shot at, but I can guarantee you that they have PTSD, even though I did not witness myself their abuse. Okay. So symptoms are what this is based on. This is not based on etiology. This Diagnostic and Statistical Manual. Now, believe me, look, mine is as frayed as anybody's, right? I believe in this, and yet it is all based on symptoms only, not etiology. So the fact that we have proposed we can put this in DSM-5 and we can start diagnosing these kids based on symptoms, it also means that we have to be able to diagnose them even though we don't have evidence of the mother using. Does that make sense? So I'm not going against the grain, and yet I am. Okay.
And as Barb has said to us many a time, the approaches for kids that have had prenatal alcohol exposure work for any child that has been traumatized. So we can't go wrong there.
Yeah, and you know, I say, look, I am talking higher level of care here, baby. I'm talking good. This is all good. Whatever we do is going to be good for them, right? So we go back to what I was talking about before with, and I apologize, I'm skipping back to this other thing. But if we're looking at cocooning, for example, and we're looking at these ways of working with the children and their families, this stuff would work for anybody. Look, I've been doing this in Potomac, Maryland, which is one of the richest zip codes in the country, right? For all these years. And I use this type of system to help all children, right? But this, for these children, it's way more important because they're going to have a hard time on their own doing any of this without somebody helping them. Okay. And the parents need to know this. So the parent, I call it channeling your inner Buddha. It's ABCs. Always breathe calmly. If that's the only thing you do and you just yourself, you're a vessel, and you're putting this transition space out here for that child to emotionally vomit all of their mess into the way they would when they're throwing up, and you're patting them on the back as a baby, but you're not internalizing that. You are allowing that child to you know, say what they need to, and then you're comforting them like I do my fainting goat. I am not screaming at my fainting goat when she faints. I'm saying, it's going to be okay, Rosie. I'm going to help you up. We're going to get up after this, and I'm going to massage your little legs, and you're going to feel better. And she knows that I'm there for her, right?
Yep.
And that's what children need.
Okay, we have to get going because the therapists all have a noon meeting. They have to be on.
Good. And I have a patient, my 16-year-old.
There you go.
I have patients. So thank you
so much.
And I will be happy to return. And in that case, stay tuned.
Excellent. Okay. Thanks, Dr. Rich.
Thank you for this opportunity. Really, I really appreciate it.
Yeah, we appreciate your time too. Have a good day, everybody.
Okay.
Bye-bye,
Take care. Bye-bye.
Bye. Thank you.
Bye, Barb.
Bye. Oh, geez, Toby, you scared me, a little fluffer nut.
Recording a Zoom meeting is a simple process. Just select the record icon at the bottom of your Zoom meeting window. Zoom offers two options for recording. Record to this computer will save the file locally on your computer in an MP4 format, while recording to the cloud will save directly to Zoom's website and is optimal if you plan to share the recording later. If you do not see an option here, you are likely recording directly to your computer. Unless you're recording automatically, select your option to begin recording your meeting. Once you're recording, you can pause or stop the recording at any point during the Zoom meeting. Once you end the session, There will be a brief conversion process where you will see the recorded file is completed.